You're like, it's so clean. I know I think you see it. But yeah, it's that. And you have to talk to it. Like, if you're this
Sure.
yeah.
Hi, everybody, and welcome to our first seminar of fall 2024. We have a great lineup this year. Ready to see you all here today. Today's speaker is Jacqueline Fox. She is a professor of law at the Joseph F. Rice School of Law at the University of South Carolina. Professor Fox received her JD and LLM from Georgetown and was a postdoc here and in our program that's jointly administered with Georgetown Greenwell Fellowship, and a Donahue Visiting Scholar in Research Ethics at Yale, and recently completed a Fulbright Global Scholar Fellowship at the O'Hara Center for Practical Ethics at Oxford and Melbourne Law School. Her research interests focus on the intersection of the law and policy of healthcare financing mechanisms and bioethics. And her current project is a comparative study of methods used to calculate the amount of money spent on healthcare and how these methods can do harm and good. Her talk today. Up here, a long title of the Coherent, Radical, Logical, Unspoken Ethical Theory likely underlying the Biden-Harris administration approach to health policy. Please join me in welcoming Jacqueline Fox.
That title is a very lawyerly title. It's meant to say that I'm not speaking on behalf of anybody about anything, just thinking, which is what I get to do for a living. So that's, that's not on behalf of anyone. It's just me, thinking about it. I wanted to start because this is being recorded, and in case anyone listens who's involved with the Greenwell, I just wanted to say thank you. It's really special being back here. It has been almost a quarter century since Ruth Thaden decided to let me be a postdoc, pulling me out of practice, and I started working in health policy and bioethics. I had never studied bioethics. My practice was very heavily focused on health policy. The time I spent here was transformative, and it made me an academic. I remember sitting in some of the first fellowship meetings and thinking, wait, people get paid to do this part? And she had promised me you could. And so it was with great happiness that I sank more and more into that side of my life. I was somewhat non-traditional because I practiced law for a few years before moving into this world. And I worked in financing, in securities and tax law, and then gradually moving into healthcare and then access to care issues. It was a big flip. So my focus has always been on the money. And I come to this field early in my career, just a tremendous familiarity with the people who were working with securities law, going for profit, just how boards of directors work, how companies work. And I really stress to my students that I think it's really helpful and important to have that background when you come into healthcare, because healthcare is money, right? And money, so much money flows through the healthcare coffers, right? It's, I mean, another project I'm working in is how much we spend, and is that real? But just for purposes of our conversation, it's between 17 and 20% of every dollar in this country is touched by healthcare in a given year, right? Like if you could leave a mark on a dollar bill every time it passes through the healthcare system, it's all touching the healthcare system, right? And when you've got stuff like that, you have people who take a lot of money out of the system. And what this project's about, it's a really long law review article, to be frank, that's coming out in a month or so. And I'm trying to make this sort of coherent and shorter than that for this talk. But what I have been thinking for a while, and what I started seeing signs of in the Biden-Harris administration, is finally looking at this system in a way that seems much more coherent and rational to me than what we've done in the past about who makes money, who we should be looking at to save money, et cetera. So let me launch into this talk and sort of explain what I'm talking about and how I think it works and why I think it's so bioethically informed and important in that way, and also what I think it can accomplish, okay? So right now, when we're looking at money in healthcare, we are always in the United States talking about exerting downward pressure on the large numbers, right? Like when we say how much we spend on healthcare every year, it's always accompanied by rhetoric about gas. We get really bad healthcare and we spend so much money. What are we doing wrong, right? I question that. Like, should we be spending more, et cetera, how we measure? Let's put that aside for right now. Within the rhetoric, within the framing of that rhetoric in this country right now, we look to people who buy health insurance to save money, right? Like pay for your health insurance, have a deductible, have co-payments, have some skin in the game, as though your health is not literally enough skin to have in the game, right? Then we go to patients. When you're seeking care, we want you to bargain shop. We want you to not go unless you really need care. We want you to be seeking out doctors who are efficient. We want to incentivize you to use the lowest level of care you can. It's like, save us money, save us money, save us money. Then we go to doctors, hospitals, and other providers, and we say, okay, we got a lot of tools for this, right? And I'm going to go into more detail on all this in a couple of slides. Then we've got drug, device, and other suppliers. Again, we don't ask them too much to save us money. We're kind of thinking about it historically, but not much. And then we get to sources of capital, investors, and management teams. And the reason this is written this way is because I believe that for the last few decades, certainly since the 1980s, this is the order in which we're looking at people to justify the money they're getting from the healthcare system. That we ask the purchasers of health insurance to justify it the most, then patients, then doctors and hospitals. You know, why are we getting paid that much? Can't you take a pay cut? Then the drug and device ones, we're always worried about their incentive structure. And then the capital investors, we don't even ask, okay? So purchasers, when someone's buying health insurance, right? We ask them to make decisions. How much do you think you're going to spend on healthcare in a given year? How the hell are they supposed to know how much? The actuarial calculator could not tell you what one individual statistical point is going to spend. They can tell you across populations, right, what's going to happen. But one person, what are they supposed to know? And they're like, well, if you have a chronic condition, how do you know that's all you're going to have? I mean, chronic conditions increase your risk of other things happening, to be frank, right? Plus, when you're most strained financially is when you're most likely to run into some other things that might be preventable if you had more money. We all know this. We're sophisticated enough in this realm in particular to grasp that, right? How when you have vulnerabilities, in some cases, they multiply and increase your vulnerability. So we're doing this crazy ask of people when they're figuring out what health insurance they're supposed to buy. Like, what is your copayment going to be? What are the deductibles? What kind of network? What kind of medications does your insurance cover? Like, I have another article that goes into detail about just how much of a gaslighting this really is, to act like a person is sophisticated enough and has reliable data enough to make an informed choice like this. Now, if you've got money and you're risk averse, and you don't need money, you just need money, okay? Like I have money. I don't have money, or money. But I got enough where I go, okay, I'm going to take a low deductible Blue Cross Blue Shield plan. And I got my reasons, right? I want to be able to go anywhere in the country that also accepts Blue Cross Blue Shield. Like I'm being risk averse and I have enough funding to handle that level of risk aversion. Anyway, then we have the known flaws, right? With the system. People are being asked to choose amongst deductibles and co-payments when the majority of Americans don't have that money. They don't have money set aside to handle $1,000 or $500 of unexpected money. They're living paycheck to paycheck where they're already allocated in a debt realm, so that they're like waiting for money back when they file the taxes to settle the expenses they know they have. They're making very complicated resource allocation decisions in their private life. So what they're doing very often is picking insurance because you can't get treated for certain conditions unless you show that you have insurance. So they're paying for insurance not because they can afford the co-payments and deductibles, but because they need that paper to access the healthcare system. They're making a calculated choice to purchase something that they cannot afford to actually use, because if it's down to life or death, they're going to use it to get into those systems, right? So these are known flaws, I think, at this point. We've become very aware, and they have very powerfully problematic effects on people, right? In terms of how they access healthcare and the outcomes. So that's when we get to patients, the skin in the game problem, the idea that you're going to put financial obligations on patients to make them make wise choices. Patients don't make wise choices like this because they have no information to make the choice. I'll give you an example. Someone who's having a heart attack. I don't know if you all have seen the data, but they've managed to collect this in numerous populations. The amount of time it takes you to go to the hospital when you're actually having a heart attack depends on how much of a deductible you have left and how much money you have to satisfy that deductible. Now, time is heart muscle, right? Like the faster you get to an ER, the better your outcome's gonna be. So this has like really obvious tracking effects about the size of your deductible, how much money you have in savings, and how well you're gonna do having an actual heart attack. And it tracks for lots of things. Dental abscesses, other problems we have that could be helped with earlier things. The other thing is, though, that even if you decide you need to go, you don't know how much it's going to cost you. And the reason you don't know how much it's going to cost you is because you don't know, because you're not a physician, right? Like what kind of tests are going to be required to do diagnostic work. And then the doctor doesn't know what those tests are going to reveal, or they wouldn't do the tests. There's like a logic train here that leads to a really problematic thing when we try and put this pressure on patients to be making these decisions before any tests are done. It's like, you're not an actuarial, you're not a physician, and an actuarial and a physician would tell you they can't tell you if they don't have enough data. But we're saying here, you make those choices, and that's gonna help us keep costs down, because you're the great place to do that. Sorry if I sound angry, because it's just so stupid though. Like when you step back and look at this kind of obligation we're trying to place on the patient. So let's move to providers. With providers, we've got, let's see if we can pay you less. Let's see if we can negotiate this and reduce reimbursements. We'll do some of this with carrot and stick to incentivize quality, but the goal is to try and drive it down, right? Let's create new systems to increase efficiencies, again, to drive costs down. Let's bring in people with less training and try and pull off from the system, right? Care that can be properly treated that way. I'm a big fan of dental therapists, so I'm not knocking this, by the way, as a really useful way of providing care to people. I get the tension of cost, quality, and access. I'm not denying any of that in this list. But we've been focusing on this as a big way of wringing out savings in the system. I think we're over-focused on it, right? But the other thing we do is we have these financial incentives that are supposed to shape care decisions. And we say, this is a good idea. It has not been a good idea. I'm just going to say that. If you start back with HMOs, once we left the employer focused original Kaiser plant, where it was a building next to the Kaiser steel plant, where the doctors they hired from around the country were passionately committed to the undertaking they were doing and were paid one salary, that we didn't have Kaiser Perm Corp with property investments and partnership rights. We didn't have any of that stuff. That worked. It was wonderful. Everything I've ever read, all the doctors I've ever talked to who were involved in that back in the early stages of my career, wonderful thing. Since then, what we have are unintended consequences and distortions and whack-a-mole problems, right? It doesn't mean we don't use financial incentives, but I do think we have to understand that you need an enormous commitment to nimbleness and non-judginess when they go off the rails so that you can respond accurately and realize, because you're creating the incentive which drives the behavior, which overdrives. Plus, you have doctors who are extremely risk averse as a culture. So once you throw in there like a fraud and abuse possibility on one side and a financial incentive on the other, you over incentivize them in certain directions like really easily. And so if you devise a really nice program where the incentives are supposed to be delicate and you have terminology, oh, we want you to do this sort of care to this level, but then you have a criminal sanction over here, I promise you, they're going to be over here. They're not going to be right next to that criminal incentive. So we don't get where we want to go because the culture doesn't work well with those kinds of incentives. And I say this as someone who teaches fraud and abuse as a law professor, right? And has to work with hospitals and things. No one wants to go to jail. No one wants to be called a criminal. No one wants to be fined. Not to mention, and a lot of people aren't necessarily aware of this, but when your institution screws up, the federal government steps in and manages it for quite some time. So you lose all authority over that institution if you've screwed up with like negligent billing and stuff like that. So people are very risk averse with that. So then you get to expanding fraud and abuse. They say, well, we've tried all this stuff, but we still feel like doctors are doing too much. Like maybe there's some cases where they shouldn't. Maybe what we should do is take away their license, sue them for fraud and abuse. when we question the medical necessity of the type of care they're providing. Where you saw this in the stuff that we've mostly learned about, it would be with the earlier arguments about pain treatment. I don't know if you remember this, it's before the Sacklers, before all that, you had some people who really needed intense pain, and a lot of doctors were scared to prescribe the necessary opioids for it. And the doctors who did were being attacked from every possible position, right? And it's kind of ironic after that, now where we are with pain, but these are people who definitely needed those massive doses of opioids. I don't think anyone's ever said that someone who's dying of cancer doesn't need that, but you had them going after the doctors in an effort to scale back this stuff and see if we could use those tools. So then we get to drug and device companies. They need financial incentive to create new products. We got a very different tone here. They need funding for early stage research. Let's use academic centers. Let's encourage bench research where we don't know what the applications are going to be. Let's fund this. Let's solve cancer. Let's solve heart disease. Let's get the federal government tax dollars into there, right? And then we have the best outcome if you invent something is for it to go to market. Let's get that into a drug company. Let them do the testing. Let them work with the FDA to get the market licensing so they can take it to market, right? And then we get the Bayh-Dole Act, which now has been flipped on its head in the Biden-Harris administration. But the early iterations of the Bayh-Dole Act said, if you invent something that's marketable in a university and you don't take it to market, and any federal dollars went towards your research, a private company can march in and take it from you and take it to market, because it's so important for this stuff to be sold. That's how we have been focusing on this. When we talk about drug pricing, if you look back over the last 20, 30 years about drug pricing, I'll give you a hypothetical actually. You may know hepatitis C, right? And I'm betting a lot of people have worked here on different aspects of the hepatitis C medication, right? So hepatitis C is terrible. It's widespread. It's in very vulnerable populations. You've got a lot of prisoners, a lot of people with histories of drug abuse, a lot of poor people who haven't had really good access to medical care, right? So we've got that whole group. Plus it's in other populations, right? And then a wonder drug gets invented. And the wonder drug is a pill that cures hepatitis C, cures it. This is extraordinary when you think about what hepatitis C could do. And the company that's invented it, right, has done some federally funded research, has done some bench research, has done a tremendous amount. And they're planning on selling this at a pretty substantial profit, right? And most people are like, kudos to you, right? Like, you're going to solve this huge problem, whatever. And then another company comes in and buys the drug from the original company. They buy that company and they double the already high price. So they go to market with this crazy tens and tens of thousands of dollars price for one effective dose of the drug, the number of pills it needs to cure hepatitis C, that costs tens of dollars to literally make. We're not talking about one of the really complicated biological drugs or anything, right? And the way people responded was to say prisoners aren't worth that money, to say poor people aren't worth that money, to say, I don't know if the cost effectiveness of this drug matches what you're charging. So then they look at how much it costs to treat hepatitis C across a lifetime. And we could argue on the edges of this. Well, what about the work they do? What about the family they do? Hold up. Why are we looking there? This is my question, right? Like, why do we start looking at justifying the price? I want you to hold that question. Like, how else could we look at this scenario, right? When we're looking at that price that they're doing, how do we ethically construct the questions we're going to ask? And then we get to investors. The investors are in the background historically, right? They're providing the funding, they're providing stock options or loans, they're investing, they have the real estate. They do a lot of things with this, right? And we're kind of like, free market? Investors, know what they're doing. These are big, sophisticated people with money. They know what they're doing. We believe in trickle down. We want them making their money. You all own stocks in these companies. You want them to do well. These are the big guys. We need to let them be. You may hear in my voice a slightly different ranking, right? Of who I'm suspicious of, who I'm looking at, than what that first list would say. And it's not because I don't like investors. paid for my first car. Investors. But no, I mean, I think there is a role for this. But I want to leave you with a second question as I sort of launch into this. The first question was, why do we look at a drug price that way, right? And the second question is, well, it's not even a question, it's a statement. And I love this statement. It's pigs get fat and hogs get slaughtered. And it's used a lot in financing when you're looking at policy situations, right? A pig is someone who looks at a situation and happily does what they're going to do. And they get good and fat and they're good. And they're like at the top level of what you'd say is a reasonable reimbursement for things. They're playing the game, but they're playing it properly and doing well. It's like someone who bought a house. They didn't destroy a neighborhood. They just bought a good house. They maybe tinkered with the layout of the hallway. The house did well over time. And they've got a lot of money now in that house. And we're kind of like, you know what? Good job. Like, I want to emulate you next time I go buy a house. Like, what color did you paint it so it sold so well? They do the little things, you know what I mean? They're a pig. They're not bad. They're very successful, right? A hog is someone who goes too far in this metaphor. And this is a commonly used metaphor. I'm not making it up in economics, right? A hog goes too far. They distort, they push the edges. They're the kind of person that leads to the IRS having a catch-all where they're allowed to go after you for what's called tax avoidance, even if you're on paper following the rules. It's because you've been a hog. Another way of looking at this is that we're all going along and then some people just stick their heads up. They've just done too much. They draw the attention of everyone, right? So in the healthcare financing system, investors and drug companies and device manufacturers do sometimes tip over into being hogs. And sometimes they do get attention, right? And they get pushed back down into the pig realm. You'll see this in investigations and public things about greed, the big fights about epinephrine, the pills, the injections that stop allergic reactions. Remember, they suddenly went up in price to hundreds of dollars and someone gets called in front of Congress and yelled at. That's the hog that gets the attention, right? So don't think this doesn't happen regularly, but it means that our debate historically has been between hog and pig. You're allowed to be a pig, but you shouldn't be a hog. Meanwhile, we're looking at patients and saying you need skin in the game. You need to be careful. Should you go to the hospital when you're having a heart attack? There's a distinction here, and I'm not sure we're asking the questions in the right direction. All right. Now, insurance companies matter. They play a role in all of this. Drug company middlemen, you know, the ones that are leading to all this chaos in drug purchasing, whatever, matter also. They're regulated also. We've got issues about them. I could talk about that, but this is getting very long. So I'm kind of just saying, yes, that all exists too and fits within this realm. I'm going to kind of put it off to the side. The Affordable Care Act has some limitations of insurer profitability. There are ways around that. The same problems are occurring within insurance companies, but they're not as interesting, to be frank, and they have different kinds of expenditures. Sometimes insurance companies are acting as healthcare providers, sometimes they're acting as patient representatives, sometimes they're acting as investors. They sort of fit in different ways into the hierarchy I'm laying out. So I'm just kind of pushing that to the side right now for purposes of the talk here. But if you're thinking, what about them? I would say yes, okay? And I'm willing to take questions on them afterwards, but I'm just kind of putting that off to the side for now. So I flip it. I say we should be looking at investors first, drug companies second, providers third, patients fourth, and then the people purchasing insurance last. Then when we're talking about who is spending money, right, we should be looking this other way. And I want to explain why I do this. Money is how we ration care in the United States, primarily, okay? Think about the whole system. And I have pages where I explain this sort of big statement, but hopefully in this room in particular, I don't have to show a lot of citations to justify this. But the fact is, if you have money, you get more care. Now, we're bad right now about where you are versus your access to specialty care, no matter how much money you have. And we're not good right now in terms of wait lists about access to care. I know Hopkins, for example, very often is getting people from DC because they don't have enough of any given specialty at a certain time. And so they're sending patients out here to see an oncologist who can see them, a neurologist who can see them, and it's going back and forth. That shouldn't be happening in major metropolitan areas. So I get that the chaos we've got by not having an organized system, by not having enough resident slots, et cetera, historically has led to misallocation of providers. But the primary mechanism that we use is money. And we've been using it for decades. You can see this in how people debate whether we should have a national health insurance policy. They slip up sometimes and they'll say things like, but wait times will go up if everybody has access through insurance and doesn't have co-payments that stop them from going. And you kind of want to stop and go, why is that? No, why is that? Can you draw me a chart? Why is that? They don't say it, but they're saying it, right? There's this understanding, it's a sotto voce kind of understanding when we have these debates, that if everybody had access, the allocation might look different, because right now, money stops a lot of people from making claims on the scarce resources we have, right? So we know it, we talk about it, but we don't talk about it head on, right? We say America doesn't ration healthcare, asterisk, this is how I'm defining rationing. So part of the work in my article is fleshing out the definition of rationing and showing that monetary-based rationing is a form of rationing. And that, maybe we can just say rationing in my article if you're not going to concede that, to people who just say that. Because you could look at other kinds of rationing plans that aren't monetarily based, right? Like what happened in Maryland decades ago where they had a shortage of flu shots. And they did this really cool rationing thing where what they did was they said, okay, people 65 and older probably need the flu shot most. And they were pretty transparent. They were like, giving it to kids would be best, but we don't have enough to give it to all the kids. We'll give it to people 65 and older. They're most vulnerable. It won't work the best in them, but they're the ones who are going to die of the flu. But we don't have enough for everyone 65 and over. So what we're going to do is have a lottery of all the citizens in Maryland who are 65 and over. And as we get the flu shots and your number comes up, you'll get it. And people are kind of like, in an ideal world, we would not have this shortage, but okay. That's your classic form of rationing, right? You did the work in the background to come up with the most vulnerable population who's going to get the biggest bang for the buck of the scarce resource. And then you came up with a way that doesn't use what we would call ethically indefensible qualifications to allocate it within the group when you have no defensible mechanisms to make it any smaller, right? It's like very ethically sound. I don't really need to do the work on that, I think, to say that. Obviously, some people have other ethical frameworks where that would not be sound. I'm not saying that's not legitimate, but in your sort of bread and butter middle road ethics, that's a pretty sound, right? That's not what I'm talking about, though, right? I'm saying price matters, dollars matter. And what I think is most interesting about that from a bioethical standpoint, not a legal standpoint, but a bioethical one, is that means that when you make a profit from the healthcare system, and when you set prices in the healthcare system, you are doing something with foreseeable ethical implications. The price you set determines who gets access to the medication. It doesn't just do that, though. In a scheme with scarce resources, the price you set also means other people don't get access to other forms of healthcare because you're taking money out of the system. So these are two very dramatic effects that occur when you set prices, and they are absolutely foreseeable, right? And I don't think we should have, I'm not calling for like some law that says you can't make a profit. Just to be clear, I may at some point in my life get cranky and call for that, but that's not what I'm doing here. All I'm saying here is it seems to me that when you're making a decision that has those kind of extraordinary foreseeable effects, you should explain yourself. Seems fair to me. You should be explaining your reasoning, right? That ethics, maybe it doesn't require you to be altruistic, but it certainly requires you to acknowledge the effects of what you're doing and how you justify what you're doing in the system. Because think about how you're getting paid, right? You're shaking down sick people who have no other choice. That's a lot of power. Or you're making these deals, right, with other companies that are responsible for providing this care to sick people. You have leverage, and you're taking advantage of federal programs that give you, like with drugs, you have this exclusivity licensing. So no one else is even allowed to do it. You have criminal law supporting you, as well as like the ability to go to court and sue people for damages if they try and provide this in another way to people. You have power. And you should explain yourself. That's basically it. It's kind of a small claim, right? What's radical is we simply haven't made that claim before. So the question is why not? And I want to explain who this claim attaches to in my view of this, and how I do this. Okay, so if we ration Oh, wait, sorry, I went ahead of myself. I don't usually use PowerPoints. So I want to go back to how we make this claim and who needs to support it. Go back to that list I had where I started with the investors and then it was drug companies. To me, the way you think about who needs to justify themselves the most is you look at whose hands are providing for patients and who is sick. So if you start at the center of healthcare, you go to the patient and you go to the doctor-patient relationship, right? It's at the center of everything we're working on because that's where the care is happening, right? So if you're sick or you're literally touching a person to heal them, I feel like you're already providing some value in this system, right? You're literally setting a broken bone. You're finding the rash and figuring out what to do about it. Like, you kind of have an easier lift, right? And the further away you get from that, the more I'm going to look at you and say, explain yourself. So if you're a drug company or a device manufacturer, or you're providing wheelchairs or some hard substance like that, you are providing a good. I'm not negating that, right? In this sort of worldview, but it's not the same quality. You're doing something in a manufacturing process that could be done efficiently, could be not. You have literally concrete costs about supplies. You do need to make a living, but you're not at the heart of the interaction with the human being. Plus you have scale, right? Your profitability can be tweaked by scale of providing. You're not limited in the same way someone who's providing hands-on care is to the amount of profitability. I'm going to look at you and say, explain yourself. How you set that drug price, and think back to that hepatitis C. Are you justified in setting that price? Not, can we argue that price will generate sufficient savings by curing these illnesses, et cetera, downstream so that we're willing to pay it? We're going to look at you and go, why are you charging that much? Why exactly are you doing that? Then we go one step up and we get to these investors. Why do you exist? What are you doing? Like you're here, you're doing this thing. Why? Like, why aren't they just getting a regular old loan like I did to buy my house? Like, why is anything funny happening here? Right? Like, what are you doing? I'm going to look at you very suspiciously, right? Because I don't like you. Like from the beginning, I'm like, why are you coming into healthcare and taking money out of healthcare when you're not providing healthcare? You're not providing a good or service in healthcare. You're buying, we already know this happened, right? Because these people went and bought all the nursing homes to turn them into real estate investments and the quality went down there study after study. I don't like you. I want you to explain yourself. So I'm most negative to someone who's merely providing investment structures and is fiddling with like ownership shares and doctor practices and things like that. I'm like, you're complicating things. You know, we're really used to being upset with like insurance companies who complicate doctors' practices with like rules and stuff. But I'll tell you, a private equity company coming in and buying a doctor's practice is complicating it a lot more. All right, so moving along, right? I'm going to say that what the Biden-Harris administration is doing and what I really approve of, and I'm going to try and talk just for another 10 minutes and bring this together, is showing that we're getting more women involved in governance, is showing that what have traditionally been the skill sets that gendered norms teach women to build, and that doesn't mean men don't have these skill sets, but it is very gendered historically, right? You can start to see this play out in Biden-Harris administration choices they've been making and the language they're using. And I want to explain for a second what I mean by that. Women historically in the United States make the vast majority of healthcare resource allocation decisions, like the hardest ones, because they're the ones who are in charge of their family money. Women generally in families put off their own healthcare at a much higher rate than other people do because they're trying to make sure they meet the other needs. They're balancing healthcare needs with school needs, with after school care, with food. They're making healthcare writ large decisions for a lot of people, and they routinely have been encultured to make very, very hard, steely-eyed, cold-eyed decisions where they very often put themselves last. And the statistics just show this over and over again. I'm not claiming this at 100% and the but me-isms or whatever. I'm sure you're all very good people. I don't mean that. But I'm talking about just how the numbers go and what we're trained to do, like who looks for coupons, who knows that this kind of rationing happens. So this has been happening for decades in the country, even as there's been this belief in healthcare policy, certainly when I was coming up, that you can't talk openly about rationing. I always thought that sounded weird. I came into this like in because the early 2000s. And I was like, what do you mean we can't talk openly about this? But in the last couple of decades, with the rise of feminist legal analysis, I've started to realize why there was this confusion. It's because I was raised to make those decisions and to look at it really obviously and to know everyone's making those decisions. Whereas a lot of the people writing about this were guys who simply thought that people were too cute and pretty and sweet to be thinking about such hard things, and that there would be this enormous political pushback if you acknowledged it frankly. I really think that's why that's been considered like politically impossible, is this diminution of the work that women have been doing in families for decades. So I got a problem with that. And I think the women coming in, and this is Harris, I think, if you look at her proposals when she was running for president the last time, and then what's been happening in the Biden administration, you start to see this is changing things. If you look at Elizabeth Warren, this is changing things. What do I mean by that? The drug negotiations I'm about to talk about, the factors that are considered in that reflect this kind of lived experience that women have in their families. Bargain shopping, how much is it worth to the family? What does it cost? This kind of rational decision-making about fairness, about cost, about what people's needs are. The Medicare, just capping the cost for certain kinds of insulin, just saying, we don't want you paying more than that. Very focused on patient experience and on the kinds of budget needs that people have. It's not engaging in a lot of conversation at a higher level about incentives. It's just saying we need to take care of this. It's an emergency at that level. But more recently, and after I wrote this piece, there have been hearings about private equity in Congress that have been fascinating because they use this language. What are you doing? What are you bringing to the table? And there have been 2 bills that have just been proposed recently that really reflect this. And the one I love a lot is the Health Over Wealth Act that just got proposed. And in it, they're asking HHS, Health and Human Services, to issue licenses to private equity where they have to explain themselves to get a license to invest in healthcare. This is the flip. This is not pandering anymore. It's not bowing in the direction of capital. It's saying, what are you bringing? So now I want to talk about the factors, the specific factors, okay, that are in the Inflation Reduction Act of 2022 that created this thing. So for those who aren't familiar, Medicare now has the power to negotiate drug prices for like the top 10 biggest money makers that aren't these really fancy biologics. Okay, that's like a very reduction of what they do, but they can now negotiate with the drug companies, right? And that's all interesting, and people have feelings. And obviously there are a lot of lawsuits, it's huge money on the line, et cetera. I'm not super interested in that for purposes of what I'm talking about here. What I'm interested in is what they want to know, what they think matters, and what their goals are, okay? So I'm just gonna read a little from my paper on this because it's kind of complicated and I wanna make sure I get it right. The goal is to determine the quote, maximum fair price for the chosen drug. That's what the whole process of the negotiation process is. That's the pig, not the hog. Do you get how that fits? The maximum fair price. It's not saying we're going to give you the minimum or the medium or the maximum, but we at least want to know what that is, right? And they have a method for calculating this ceiling of the maximum fair price. And it's got 2 sets of factors, right? I think it's reasonable to read the law as seeking fairness in pricing because they use the word fairness, where fair is defined through reference to the factors they are ordered to consider. It's a shall consider when considering the price, right? So now we're thinking, what does fair mean when it comes to the prices set by a drug company, right? So what do we look at? Research and development costs that the manufacturer has incurred. So if they purchase it from someone else, they're getting a licensing. That's a different kind of cost. They don't get to blend in all of those costs like double dip. That's the cost we got to purchase it, plus is the cost. It's the manufacturer incurred these costs, right? And it raises the question of what you do with earlier research, right? And where in the timeline the manufacturer gets it. But that seems fair to look at that and separate those out, right? If they didn't spend the money and the time and the risk, it's a different thing. The extent to which they've recouped their costs by the time it comes up for debate. Did you make a lot of money? How much have you made so far? The per unit cost of manufacturing and distributing the drug. This allows us to recognize that some drugs are very, very expensive to either manufacture or store, and some are cheap as all hell, right? There are a couple of pennies, less than a penny, a fraction of a penny per drug, right? It just depends. It's a factual question. Prior federal support for research that led to the development of the drug. Did we already pay for this? Just asking for a friend, is this us who did this? Seems fair to ask, I think. It's meant to reflect the risk that the companies might take in developing new inventions, right? What did you really do? This flips Bayh-Dole, by the way. The Biden-Harris administration has been saying Bayh-Dole, the act that allowed the march-in rights, should also be allowed to march in if you're charging too much, if you're getting crazy here. We should be allowed to do this because the goal of Bayh-Dole, right? Get things to market so people can benefit from them. If you're screwing around with the pricing, that's not getting it to market so we can benefit from them. Do you see how they're flipping the whole analysis there with that interpretation? So interesting. And then you have to do a consideration of any pending applications for exclusive marketing, such as new patents or licenses. This is where you've got a drug that's on the market and you're trying to get like a slight alteration in it and maybe get a new license or whatever. They want to think about that because that's going to be a huge profit flood for them, right? Or it may be that they're coming up with a new use and we want to be protective of them. There's a robust way of looking at this, but it allows that. Then we look at, I think that when you look at those factors, what you get is, am I doing all right on time? Okay. When you look at those factors, what you get is a, this idea of reasonableness. And this is where I think I've kind of formulated what I think is the ethos that they're bringing to this when you look at that. A company ought to be paid a reasonable amount of money that allows for it to recoup its investments and remain incentivized to undertake potentially financially risky scientific investigations that can lead to new drugs, but it should not be reimbursed for costs and risks it did not bear. And that's my formulation. That's not theirs. It's just, I'm a torts professor as well, and the reasonably prudent person plays a big role in this. And I think that what they're doing and why I think it ties into a lot of feminist legal literature is this use of reasonableness, is this use of fairness, reflects people who have to balance a lot of other people's claims and needs routinely and are used to making really hard decisions. Within that balancing, it's bringing that energy and that knowledge base into how we look at healthcare spending. It's shifting the moment away from the provision of care and all those negotiations and putting more and more on the patients and providers, do more with less, and coming back and saying, hold on, why are we giving you all this money? And there's some other stuff that happens here that I don't really have time to discuss. The second set of factors, it's evidence about alternative treatments. It's also really interesting how it's done. The one thing I want to signal about that is it expressly says in both the law and the regulations over and over again, that one of the factors we're most interested in here is how your drug does a better job of protecting vulnerable populations than other treatments that may be out there. It's the exact flip of the kind of isolation and unfairness that people expect from rationing, where they say, oh, it's gonna kill vulnerable populations. This expressly calls for an increased value of a drug or treatment if it helps offset the unfairness that vulnerable populations are already experiencing, which again is so radical to me. And it also is so logical and so close to the heart of the kind of people who are making these sorts of decisions, like regular people in their lives. To me, it's a breath of fresh air. I'm not saying it's completely transforming everything, but I think it needs to be called what it is. I probably would not use the word feminist in the current universe, like talking about this, but I think that Harris should be taking a victory lap for bringing this kind of fresh air into how we talk about health policy. The stuff about vulnerable populations and social justice is recurring throughout the administration. I really think it's her energy. I don't think Biden opposes it, but it's simply not something he's ever worked on before. And it wasn't in the Obama-Biden administration in this clear way. So I look at who's new and who has said this stuff prior to it, and I think it's her. And I think it's really important, and I think it resonates with people. So that is my talk. Thank you very much for listening. And I am happy to take questions. I think I got in right on time, did I?
We got plenty of time.
All
Yes. So, yeah, we are here till the top of the hour. Coming up.
I say I'm happy to take questions, but I don't know if I can answer them. I'm willing to give it a try.
Thank you. That was fascinating and very persuasive. But I have a question about the manufacturer specific factors that are used to calculate reasonable profit. So I don't know very much about this, but I guess my assumption is that you have drug companies that try out a lot of different pathways to creating new drugs, and most of them fail. And then they'll have a successful one. And so when you're trying to figure out like how much should a company profit from their successful drug A? Do you include just the cost associated with developing drug A? Or do you also include something to reflect the unsuccessful drug B, C, D, E that they tried to create? Because we want them to try, right?
Yeah,
We don't want this to suppress innovation. So you don't want to limit profits enough that you suppress innovation too much. So yeah, that's my question.
yeah, no, there's not a lot of specific elements that look at ones that they've tried and failed at. But I think that reasonableness does leave room for that. If you're talking about like, for example, we're trying to do a whole area of fixing XYZ, and this is part of that, I think you could probably do that. But no, it's not interested in that. I will say though, that the data shows that is somewhat overstated. Because the drug companies very rarely are investing. They do, don't get me wrong, but they're not spending as much money in that alone as they are through research partnerships with universities and other ones that are receiving a lot of federal funding. And then a lot of the research that's being done now, a lot of the testing of early stage stuff is actually being done on computers. It's like a really shifting environment for that. Like look at what happened with the development of newer forms of vaccines. We're entering an absolutely glorious world, right? Where the power we've got to affect positive change in healthcare is extraordinary, but it's also not super expensive. Some of this stuff. So I'm not super worried about it. I think it's a valid point, but I think it's more of an historical vestige. It could be that something would come along that would require that, but it would be pretty surprising to have a drug company in the United States doing that without federal funding, without a research institution, like spending that money. Where they tend to spend the most money is on the testing of the drug and the application for exclusivity, like usually, and the marketing. But I'm open to hearing a counter story to that. Other questions? Yeah.
So this is really interesting. This is kind of my area of study, but I'm a sociologist, so coming at it from a different.
Ooh, yes, no, sociologists have very cool things to say about health insurance and stuff.
But I'm interested in something kind of specific about the margin price. Right, this has been something that's been, they've been allowed to do this for years and they haven't. The last I had kind of understood about the administration was a little bit hand-wavy, but maybe if you could explain a little more about the margin rates, what's different now. I thought there have been some opportunities for them to utilize this and they didn't recently. But I could be wrong, and so just.
No, you're absolutely right. Bidol has never been used. I would say it's a saber that rattles, right? And it tells you what the federal government wants you to be doing. And then people do it because they don't want to have their stuff taken. So I think part of the reason why you'll see drug companies willing to participate more with certain pricing modifications and things is because of that saber rattling, that it's showing, I mean, that's at least how I heard it. And it's just me. I mean, historically, it was used because they didn't want people just sitting on stuff and publishing an article about efficacy and then getting promotion and tenure and another like grant. They were like, that's great. I get the incentive and your structure is that, but we need to set up a system so that you see dollar signs, so that you license it and monetize it and get it done, right? Because we're all aware of the incentives within academic institutions, and they weren't historically, like back in the 80s, they weren't focused on profiting from the inventions in the same way. Universities didn't claim your intellectual property in the same way. They didn't have lawyers who were like experts in licensing and negotiating. When you set up your lab now, you negotiate really hard to keep certain percentages of the licensing value. It's like a big deal now. Bidol set that up to a large degree through the hearings and saying it. And once they created that structure, it just fed on itself, I think. But there are a lot of things like that in government, right? Where they say they could. And that's how historically we've gotten the hogs to back down to pig level, right? You'll see hearings that are meant to constrain people because they're like, we're looking at you. And then they kind of simmer down. They're like, you could be greedy, but you can't be overly greedy, And I feel like that's what the new iteration of Bidol was meant to do. I don't know. I literally don't know if it would withstand a lawsuit. or who would sue. I remember reading the proposal from the Biden administration and going, huh, I have to read a lot of the statute and the regulations to know for sure what that means. It's colorably enforceable, like in how they wrote it. They weren't like fibbing in how they did it. It's a reach. But honestly, marching in for the other reason would have been a reach too. Yeah. It's probably not very satisfying, but there's a lot of governance that happens through talking, right? That doesn't happen through actually doing enforcement mechanisms because people don't want that burden on them. And so industries do balk. As a sociologist, that should be something you're pretty familiar with, honestly, that kind of like unspoken governance rules. I mean, that's one of the reasons why the Trump administration has freaked so many people out, is because they simply don't follow a lot of those ideas of governance. Well, freaked out law professors because of that.
So this is great. I'm trying to make this a question, but I'm mostly confused. So I'm just gonna talk about where I'm confused. Yeah, anything's.
I may also be confused,
Yeah,
just to be fair, but yeah, come on.
A maximum fair price is like an amazing thing for many reasons. One is like, okay, so the price could just be infinite, and then if it's unfair, you just lower it. So we're in the zero sum thing where there's one reason to lower the price, and it's we translate any complaint into the language of fairness. And otherwise it doesn't matter. So we're still in this very confrontational, says like do away with capitalism. Right. Okay.
I heard some vague descriptive Marxist mutterings at the end
Sure,
of that.
sure, sure.
Okay, got it.
What I'm worried about is like translating the only reason a price should be lower into fairness is like putting it all into that one kind of language, and like what sorts of things might get left out or distorted from. I don't know how to make that like a better question. I just think this is weird.
Fair. It could mean anything. So one of the things that the law specifies in the most recent regulations that CMS came out with was that if drug companies start cherry picking data and releasing it to the public to argue that a harm is being done to them, data that is otherwise protected as confidential that CMS has gotten from the drug company, right? Because it's got a lot of things, they can now release it. CMS says, if you start it, we finish it. And what they're trying to do is stop like really wild manipulations being done with this really charged rhetoric and cherry picking of data. I think it's really, really smart. And the reason I bring it up in this context is I think it starts informing why we're scared as a population of these kind of discussions, right? Because they go off the rails really quickly. The rhetoric is so emotionally charged, right? And so detached from what's actually happening that you really have to be expert at rhetoric and emotions like that to have those public conversations. There's like a separating out, you know what I mean? The people who really like to talk about the details and the policy, and then the people who are really good at dealing with scared people who are angry kind of thing. I'm so bad at that second part that like I don't get called back to news stations, right? Because I like settle the argument and I want to go to data and they're like, you are boring. But I think it's a valid point. I think that's why the factors matter. And I think making reference to the kind of value decisions that families make, and that there's a lot of literature in feminist legal theory about this kind of decision making. And I think if you look at the studies that go to how people make difficult resource allocation decisions and what they're actually considering and what happens when cost is on the line, you are in a position to make very informed decisions. I think that the use of the word reasonable to a lawyer is full, not empty. It's thick, it has meaning. And so when I use it there and when they're using it, it matters, right? Like reasonable matters. There's like a lot of back and forth between judges and people in the role of the jury. It's not an empty term, right? So I would say, okay, I know, I think I can defend that, but I think the other worry about it is about this rhetoric. And so I do want to bring up, they're allowed to go into it, like, and fight back if it's being debated in this sort of distorted way in the public sphere.
That's helpful. So the fair is really doing the work of separating hogs from pigs. It's like trying to catch the worst abuses and say that's like unreasonable.
Well, it's gonna depend how it happens, right? There's room for some movement there in those negotiations, right? There's room for helping us learn what we value. We're babies at this. right? We're behind a lot of countries in terms of having these conversations. I don't think we're gonna jump in as very sophisticated adults having these conversations. I think we have to learn how. And that we're gonna build up through the case studies of how we do the different drugs and how it plays out. We're gonna build up a capacity, and I'm hoping it starts spilling over reflexively into lots of other areas as we get better at it. But I am very chaos tolerant personally, and I know a lot of people aren't. And so I look at that and I'm like, oh, cool, it's a process. And other people are like, sweet Jesus, it's raining frogs. You know, I mean, we have different sensitivities to that. So I sound jaunty and other people might be horrified by what I just described.
Well, we have unfortunately reached the top of the hour. Rock raining down, and
Perfect ending moment.
if you all would join me once again in thanking.